Hello and welcome to our YouTube channel. I'm Dr. Rohit Lamba, consultant orthopedic and joint replacement surgeon. Today we discuss the case of the week, which is a very interesting case and one which is very close to my heart. So this is one of the most complex of hip replacements that we get to see. This is a special case in which the hip ball has been out of the socket since birth. So what happens is usually you have this joint hip ball which stays inside this cup, and in this case the hip has been out, and this is called dysplasia. So in dysplasia there can be different varieties, in which in grade 1 it can be just slightly on the edge of the hip, or in grade 4 it is completely out and is riding very high up. So this was the case with this lady, and she had this problem on both the sides. So she had a developmental dysplasia of the hips with grade 4, and it's called CRO 4 of this typical disease. Now there are various problems attached with this. First is how to get this hip back into the original place of socket. And the second is that since the hip has been out since birth and the hip has not developed well, both the cup and the head are very small in size. They're like childlike. They're not of adult size. So the cup has not developed fully into a cup, and it is a very small opening in which you have to use special implants. So usually what we do in a hip replacement, in a normal adult, we get to see the size of this cup which we put here is anywhere from 64 millimeters even. That can depend on the size of the patient and the ethnicity. But in this case, usually we don't get to see anything more than 36 or 38 millimeters. So that is very small, and only special implants are available. A typical company, only Johnson & Johnson Depu has this kind of cup which comes in this size, 36, 38, 40 millimeters. So we have to use a special cup from them. Then we have to find the exact normal place where the cup should be found. So the dissection is very important. The surgical steps are very important. We have to take care of the nerve as well, so that it doesn't come in the way. And once we've reached the place where we have to put the cup, we find the best available bone stock, ream it and fix the cup here. So that's what we plan to do in this case. So then problem number 2. Now this hip has been riding high all the life, and because of that the length of the leg is also slightly shorter. Now when we pull it and get it down, we can't pull it so hard enough, because otherwise it will cause damage to the nerves. So what we do in this case is we have to do a sequential release of all the soft tissues around the hip. So this is the proximal hip. Apart from just the muscles which are attached here, which are called the hip abductors, rest all of the muscles have to be released. Everything has to be released. All the soft tissue attachments have to be released from the proximal femur, which is called skeletonization of the femur. So we have to achieve a near total release of all the muscles except for just the abductors. That gives us a slight leeway in order to pull it down and get it to normal. Even then it is not enough. So what we have to do after that is we have to make a cut in the bone here, just below the lesser trochanter. Over here we make a cut in the bone here, take out a piece of bone that could be around 3 to 4 centimeters, and then bring the two ends of the bone together and put a special stem inside. Now the stem has to be such kind, the normal stem would not come into this, because normal stem would not be able to fix the two ends of the bone together. So what we have to use in this case is a special cone prosthesis, which is called Wagner cone prosthesis. Now this again is a different company, it's from Zimmer. So this gives us a nice fit into the bone, because it goes like a cork in a champagne bottle. So that fixes nicely and fixes both the two ends of the bone, and it gives us a proper version as well. So we can rotate the stem as per our requirement or as per the anatomy required for the patient. So the version is also manageable, the osteotomy is manageable, and the osteotomy can be fixed with just by putting this stem. So once that is done, you have enough leeway to get the hip down and reduce it into the normal socket, and that completes your hip replacement. So now, even doing so comes with a lot of risk. Even with having taken all the precautions, sometimes you can end up having some irritation of the nerve, which can cause a foot drop. So most such cases, because the nerve has not been pulled too hard and has not been cut, so most of the cases do recover, but it does take time. So that can happen even after all the precautions. But what we've seen over the years with this technique, with this special technique and with these special kinds of implants, we've been having very good results, and patients who have been living with this problem for a long time have had very wonderful outcomes with this. Now this lady, she's a 39-year-old. I saw her in one of my visits to Kurdistan in Iraq in my clinic over there, and I counseled her about what can be done about hip condition. She had a chronically dislocated hip which was not stable, and her gait was also not normal. So she had started having pain in the hips and in the back also because of this. So I counseled her about the options that she has, and she came over to us in India. And in staged manner, she got the surgery done. So we took up for the first the right side hip replacement. A week, 10 days after that, we took her for the left side as well. And now she's around 10 days after the second surgery, and she's able to walk, putting full weight on the legs. And even having had the osteotomy on both the sides, she doesn't have the pain of that because it is nicely fixed with the stem. And she's coming back to recovery. And hopefully in the next 1.5 months, she'll achieve almost complete recovery. We'll keep you posted about her recovery, and thank you again for watching.